My name is Bryan Saltzman. I'm one of the sports medicine specialists here at the Randolph Office Sports Center, specializing in the shoulder, the elbow, and the knee. When talking about athletic knee injuries, we don't expect that to happen only in the young, high school, or collegiate age. We can see that in recreational athletes or non-athletes as well. But we get to take that professional level knowledge, that collegiate level knowledge, and adapt that into anybody that we see in the office in order to give them the best level of care, but treat them as though they're that highest level of athlete so they can get back to what they love to do. Knee injuries that concern me are those that are associated with swelling, feelings of instability, catching, locking type events. Those are the ones that I find that end up in my office because of concern that it might be injury to a ligament, the cartilage, or the meniscus. And we can't always see what's going on from an x-ray, which just shows us two-dimensional views of the bone and the space between the bones. So not uncommonly, a swollen knee for me ends up into the MRI scanner to look a little bit closer. What the MRI does is it allows us to see the bone, the cartilage, the muscles, the ligaments, the tendons, get an idea of acuity of injury or chronicity of injury, see what's going on, and determine how to best treat. So when talking about a meniscus injury, the meniscus are those two C-shaped structures, those cartilage structures in between the thigh bone and the shin bone in the knee. And those structures act like shock absorbers in the knee and can get injured anytime that you have that kind of deeper bend, twisting type activity in the knee. You might feel a pop, the knee becomes swollen. Again, those are those features where we look for pain with deep rotational movements, so twisting, getting into or out of the car, turning in bed, especially if there's associated catching or locking, which can suggest that the meniscus is injured in a way that it's unstable. And so as those things happen, we can look on exam and see, well, what sort of those provocative motions cause those sort of symptoms to replicate. There are a lot of meniscus tears and a lot of knees out there that are coexisting with the knee and can be treated with anti-inflammatory medications, physical therapy options, sometimes a cortisone injection. And so things short of surgery can treat a lot of these types of injuries, and surgery isn't always the first option, often the last option, with the exception of some of those bigger displaced injuries where the meniscus has pushed out of place, or a big tear in a young knee with an acute injury. But again, a lot of times these injuries can be amenable to non-operative measures. So when talking about ligament injuries in the knee, the one that gets the most attention out there in sports and otherwise is the one that happens most frequently, and that's injury to the ACL, or the anterior cruciate ligament. The cruciate ligaments are those crossing ligaments, hence cruciate, that we see in the knee. The ACL being anterior in the front, and the PCL, the posterior cruciate ligament, behind it. So that ACL is frequently stressed with some of those higher level movements in the knee, and it can tear as a result. And an MRI can often find that bruising pattern of the shin bone actually knocking up against the thigh as it comes back into place. And that's that mechanism for the ACL to tear. And again, when that ACL tears, it's vascular. It has blood vessels, it bleeds. That's what causes that swelling to occur. And so swollen knee with instability is an MRI and a concern for an ACL or an anterior cruciate ligament tear. So if we look here, we have an example of an ACL injury. And so what I'm showing here is an image looking on a sagittal, which is a side view of the knee. The nice thing is with an MRI, we get those three-dimensional ability to scroll through from side to side. So if I take you all the way out to the inside part of the knee, up here we're seeing thigh bone up top, we're seeing shin bone down below. These black triangular structures, that's the meniscus. And so when you see these thick black triangular structures, you know the meniscus is okay. As we get out and towards the center part of the knee, you see here, this is the posterior cruciate ligament. It looks like a comma-shaped thick black structure. That's a good ligament. What we don't see as we go a little bit over is a thick black ligament to represent the anterior cruciate ligament, the ACL, on that slide next to it. So this haziness, this gray, that's an ACL tear. To me, ACL tears, anterior cruciate ligament tears, are one of my favorite things to see and to work with. It's heartbreaking seeing them because it's often a young, active individual or a recreational athlete or somebody who tore the ACL because they were doing something that they love and that they want to get back to. From a technical standpoint, it's fun for me because it's a game of millimeters. It's a very technical surgery. It's very important to get things exactly right in order to get that tiny little ligament to function as best as possible for the athlete going forward or for the individual going forward. But the nice thing is that we can see these athletes, these individuals who are trying to remain active, go through this 9-month rehabilitation process. They become a part of my practice for a long time as a result, but I get to watch them go through each of these stages as they recover. So it's very rewarding to me to then watch them get back to the thing that they love to do. So one pathology in the shoulder that I see a lot, especially with younger athletes, but also with older individuals with falls, is shoulder dislocation. As the shoulder pops out of place, it pulls against that ring of cartilage, that labrum, which otherwise creates a suction seal. There's no other joint in the body that does what the shoulder does. It's the only part of our body that can go 180 degrees in a circle. And so it's inherently unstable. And so it relies on that suction seal of the labrum. It relies on the muscles and tendons and ligaments around it. And that first line of defense in a younger shoulder is that labrum. So when it pops out of place, it almost invariably is going to cause an injury to the labrum. And we're looking at whether we need to bring that labrum back up to the shoulder socket to reestablish that ring and suction seal so it doesn't happen again. Another thing that we often see in the office as an athletic type injury or a sports type injury or an exercise induced injury can be injury to the quadriceps or the hamstring, those big muscles around the thigh that cross across to the knee joint. They can be at particular risk of injury with some of the higher loading activities, some of those eccentric loading mechanisms as we describe them, where those muscles get elongated against a fixed point. And so not all of those are surgical injuries either. Oftentimes, in fact, they're non-surgical injuries, but they can nag and need a lot of help and treatment with our physical therapy colleagues. If any of this sounds familiar and you find yourself with a knee, shoulder, elbow injury that's in need of attention, you can call OrthoCarolina's hotlines, you can schedule online. We've got locations all across the Carolinas, and we make it as easy as possible to try and make yourselves an appointment with us at a first availability, or if you're looking for someone in particular. So we're here, we're available, and we're ready to see you.